welcome to this genitourinary history lecture on problems that affect the breast tissue. So we've already done one for the urinary system, and we'll do this one, and then there's one more referring to the remainder of the genital tissues. And so for the genital tissues, we're really just talking about structures involved in reproduction. And obviously these are sensitive private areas of the body, and so you want to be very sensitive in terms of how you ask these questions and why. Why do we treat people in that way? We do it because they are made by God in His image. They're made by God and they are valuable as such, and so we protect their dignity. We treat them with compassion. We do it with excellence. And these are also perhaps issues that you might want to shy away from. And so you want to make sure that you're doing what the patient needs because God made them and they're important and valuable, and not necessarily just what you want to do. So again, we always start with why do we do these things? Why do we do these things the way we do them? Because we want to always be mindful of the ultimate significance of the human being in front of us and make sure that we're there to serve them and not merely to do what we want to do. So, with that said, let's dive in to this topic. A few general reminders as we get started. Again, we want to stay patient-centered. We want to be focused on the patient's needs, let them tell their story, ask questions in an open-ended way, give them adequate space and time to say what they want to say, because that will help you. Getting the history that they think is important will help you ultimately build trust with them, and it will save you asking lots of questions and thinking what to ask. So stay patient-centered, stay non-judgmental, and that'll be particularly important with the final lecture. But with this one, I guess my experience has been that people will come to you with a breast mass that looks pretty clearly to be cancerous, and they've had it for months. And you want to say, why didn't you come in before now? That isn't helpful, actually, as you might imagine. So, listening. It's not that you can't address those things later on, but initially, just let them share and don't offer any judgment on what they're sharing. Just listen. Take the information in and use it to help you care for them. You definitely want to get the patient's ICE, their ICE, their ideas, their concerns, their expectations. This topic, particularly because a very common reason people come to you with complaints relative to the breast is because they think they might have cancer. And so you want to be very sensitive to that. You want to know, what do they think is going on? And how does that concern them? How is it affecting their life? And what do they expect you to do? Again, you just want to make sure you're very sensitive to their needs and stay patient-centered by doing that. It's important to remember that benign and malignant processes cause similar conditions, and that benign ones are much more common. So we worry about cancer because it's so bad, but we don't worry about it because it's 90% of the cases. We worry about it because it's a minority of the cases, but cancer is a diagnosis you cannot miss because obviously the consequences are very severe, perhaps even fatal. So remember, they may look similarly initially, and benign ones are going to happen more often. So that's important going in. And people may come with no symptoms at all. And so it's important for you to know and probe as to people's risk factors. They're not there for their symptoms sometimes. Sometimes they're there for another reason. Sometimes they're there just for a healthy checkup. And you want to make sure that you assess their risk. Also, they may come to you after a screening test has been done and need some explanation of the results or further workup or further examination. So it's not always about eliciting a complaint from the breast tissue. Okay, so excuse me. What types of symptoms might you see? So there are a couple off the top that happen very commonly. One is the breast lump. So somebody finds a mass. Maybe they noticed it in the mirror. Maybe they noticed it when they were doing breast self-examination. And of course, maybe first in their brain is this might be cancer. Maybe that's why they're there. That's why you want to get their ideas about what's going on. Of course, more common than cancer is going to be these other items, as we already talked about, that present similarly but are benign. So fibrocystic changes. For these, think about bilateral masses that are rubbery and mobile. They don't have the feel of malignancy to them. They tend to be worse premenstrually and to resolve after menstruation. And they happen in younger women in the upper outer quadrant specifically. You can think about those. Fibroadenomas, again, benign, again, rubbery masses. They're the second most common type of mass in young women, so beneath the age of 35. And again, benign. Uh, Cysts. So these you want to be careful with. They feel, of course, fluctuant, especially if they don't have a whole lot of fluid pressure in them. If the fluid pressure builds up, they may be more tender and more firm. And when you aspirate these, you're looking for a couple of things. One, you want to make sure the mass completely resolves after aspiration. If it doesn't, you have to worry about cancer. If the aspirate is bloody, you have to be careful. You want to rule out cancer. If the cyst recurs rapidly after aspiration, again, think about cancer. But otherwise, cysts are benign entities. Abscesses, of course, can occur, bacterial infection leading to abscess. These can be lactational. These tend to be located in the periphery of the breast, and of course, they're occurring in lactating women. And then non-lactational. These tend to be more central, like under the areola. And think about young women smokers who get these, and you treat them with antibiotics and drainage if necessary, of course. Okay, so another type of symptom, you have lumps and you have pain. The pain can be, and so pain, another word for that is mastalgia, so pain of the breast, mast referring to breast, algia referring to pain, so mastalgia. Cyclical is going to get worse and peak in the latter half of the menstrual cycle, or the menstrual period rather. No, I'm sorry, the menstrual cycle, near the end of the cycle, and when they menstruate, the pain should resolve. Non-cyclical pain is just there all the time. It's not associated with the menstrual cycle. All right, other symptoms to think about. Skin changes, dimpling. This could be some mobile dimpled skin over a cancer. If you have indrawing of the skin, perhaps that is skin fixed down to a cancer. Lymphedema of the breast causes the hair follicles to remain recessed as the rest of the tissues swell. And so it looks like the peel of an orange. So we call it from the French peau d'orange. And that, of course, is associated with cancer as well. Nipple or areolar eczema can, of course, be in anybody who has eczema at baseline, but it also could be Paget's disease of the breast or a manifestation of cancer. So you want to proceed carefully there. Nipple changes that occur. You can get inversion of the nipple. If that's bilateral and slit-like, we think, okay, it's probably benign. Very common. If it is distorting the nipple architecture, if it's unilateral, these types of things make us worry about cancer. Similarly with discharge. When it's bilateral, we worry a little bit less about cancer. If it's unilateral, you definitely want to investigate for cancer in that instance. Or if the discharge is bloody or anything like that, again, you want to investigate for cancer. Galactorrhea is going to be bilateral, and it's going to be associated with hyperprolactinemia, so an excess of prolactin in the bloodstream from the brain. And it is not a concern for at least breast cancer. So you evaluate their medications and their other medical problems. There may be an explanation there for why they're having this. Gynecomastia is when breast tissue is occurring in males. Now, this could be as a result of medications they're taking, like spironolactone or digoxin, and several others. This could be the result of chronic liver failure. It will certainly do this. It could be the result of a genetic syndrome like Klinefelter syndrome. All that to say, as long as it's bilateral and we can explain it with one of these other causes, then we don't worry very much about it. But if it's unilateral, if there's a family history of cancer, these types of things, we are going to go ahead and evaluate them for breast cancer as well. It can occur and does occur at times, although rarely. Okay, so just a reminder about symptoms we've talked about. They're listed there. Pain can occur from infection, from pregnancy as the breast tissue prepares for breastfeeding after birth. You can get the cyclical nostalgia we talked about. Discharge can occur with pregnancy, papillomas, duct ectasia. Of course, if there were an abscess, it could be discharge of pus. Or, of course, with cancer, rarely, especially if it's unilateral. Lumps, those are all the possibilities for lumps. We discussed those at length pretty much already. Um, if the breasts are lumpy diffusely, then again, we think more about these fibrocystic changes. And then do think about this fact that some women, one, present with no symptoms, as we already said, so they're there as the result of screening that found something, or they're there because they want to be screened, so evaluate their risk factors for breast cancer. But then also you may have people present with, say, bone pain. In other words, symptoms related to distant metastasis of a breast cancer. That does happen, and obviously the prognosis is not very good in that instance. But I've certainly had that happen in my career where women presented with metastatic breast cancer and symptoms from that. Okay, so let's get into the history. How do you do this? Again, you guys know how to get the presenting symptom. You know how to get a history of that symptom. Use Socrates or Socrates. And of course, you may not use every item from that mnemonic, but it gives you a framework to think through what types of questions you need to ask. Again, let the patient tell their story first, and then fill in details with other questions once you're finished hearing from the patient. One really important consideration that I want to stress with this is ask about the relationship to the menstrual cycle. That really can help you a lot. Breasts are hormonally responsive tissues, and so you want to know about how things are timed with relation to the menstrual cycle. That's unique to this history. Also, with this history, really be very, very careful to quantify their risk for breast cancer. In other words, to get at their cancer risk factors. It gives you an idea of the context in which you're putting the symptom they're presenting with. So, what are those factors? Of course, being female makes you more likely to have breast cancer. Being older makes you more likely to have breast cancer. Certainly, family history. So, in the history, I really do focus in on family history. So, things like family history of someone who had an early age of onset of cancer. If there are multiple cases of breast cancer in the family, especially amongst closer relatives. If they have ovarian cancer in the family, that can signify that they may carry the BRCA or BRCA gene that could be giving them in the family breast cancer and ovarian cancer. Certainly, if they have a history of breast cancer in a male in the family, that is a higher risk situation because that's more rare and more aggressive usually. Women are more at risk if they have early menarche, in other words, if they start their menstrual cycles early in life, or if they haven't had children, or they were older when they had their first child, can also be a risk. Having late menopause, that longer exposure to estrogen can be a risk factor for breast cancer. And then, of course, for the same reason, prolonged hormone replacement therapy, we think, is a risk factor for breast cancer. Being obese, especially being obese when you're postmenopausal, is a risk factor for cancer. So you make note of that, of their BMI as you go through the history and physical examination. And then lastly, as far as their past medical history, have they had other cancers like, say, Hodgkin's disease, where they had mantle radiation that would involve the chest? Especially if they were younger, like less than 30 years of age, they are at risk later in life for breast cancer. And so you want to make note of their past medical history, of course, as well, as you go through these things. Okay, so that really is all I want to give you as far as the breast history. Hopefully that's enough to think about. But the things to highlight are, of course, let the patient talk, get their history from them, get a good history of their symptoms. Definitely ask about their timing of their symptom with the menstrual cycle. Do definitely evaluate them as to their risk for breast cancer by history. And again, listen, be compassionate, get their ideas, their concerns, their expectations, because very often they're coming to you with a concern that this could be cancer, and they're scared. They're scared for their lives, and you want to be sympathetic and empathetic with them. So if you have questions about this lecture, thank you for listening. Please contact me at the email address listed there. Additionally, not just if you have questions, but if you have comments, was this a good video, a bad video? Was it helpful? Was it not helpful? What should I add? What should I leave out? these types of comments are welcome as well. And thank you. I'll see you all in the lab very soon to practice taking history using these skills. Bye-bye.